to characterize the fundus lesions, fundus photography. If you want to focus on the lesions in the peripheral or post-equatorial retina, it's the ultraviolet field. Is the disease active and you want to monitor? Autofluorescence, many a times, may be combined with the OCT. If you are looking at a case of retinal vasculitis and want to look at the leakage, new vascularization, capillary non-perfusion, then it is fluorescein angiography, preferably ultraviolet field. If you are not sure what you are looking clinically and you want to study the choroid for granulomas or something, ICG is there. If you want to localize the lesion, you want to study some of the biomarkers, OCT. And finally, if you're looking at choroidal new vascularization as a complication you want to delineate, there comes angio-OCT. Now, choosing the right imaging modality is very important. We generally look at our retina colleagues, and whatever our retina people tell us, we start following it blindly without even understanding whether that will be applicable in the context of uveitis or not. Now, here is a picture. Multimodal imaging, we do have pseudo-color. Now, Heidelberg doesn't even have the true colors. So this is a 40-year-old man, decreased vision. So, you know, he was being treated for TB, and you look at the picture, it looks normal. You know, you don't see anything in the picture because it's a MCI picture. It's not a true color picture. And here I will show you the comparison. This is multicolor imaging where it looks normal, and the moment you go to true colors, you realize there is a granuloma sitting there which you can see on autofluorescence, but you miss out on certain other imaging modalities. Not only the presence, the disease activity. Look at the first picture where the black arrows are. Is it active edge of serpiginous choroiditis? Nobody can say that the disease is active looking at MCI, whereas when you look at the true color pictures, you do realize there is an active disease which is yellow in color. So this is what is important, that multicolor confocal scanning laser ophthalmoscopic images, which we published in the journal Retina, may not actually give you the clear picture of the way we are used to of looking at uveitis, because to us, yellow means active. To us, green doesn't mean active. So we have to relearn. So you should be very mindful of the imaging modality being used. When we come to the lesions like acute retinal necrosis and you want to follow up this patient, then the ultraviolet field is the answer. For example, we see here, this is the picture taken at baseline. Then you see 3 days later, you can see that some of these lesions which you are seeing here are disappearing here. You can monitor, add therapy, and subsequently patient develop tubular necrosis. We have to struggle, but you can actually see the edge becoming discrete, the new lesions not coming, and finally the response to therapy. So this is possible only with the ultraviolet field. Fundus autofluorescence is very useful for monitoring disease activity, especially in patients with serpiginous-like choroiditis, which is very commonly seen in India. And here you see the hyper are active, and as they start responding, they will become less hyper. You can obviously do ICG to show you more extent of the disease, but you cannot repeat ICG to monitor the disease. So you have to monitor it on a non-invasive device like autofluorescence. You keep on seeing new lesions appearing, you do the interventions, and finally you see the response to therapy. If it is a case of retinal vasculitis and you want to look at the peripheral leak, capillary non-perfusion like this one, you have to rely on your fluorescein angiography, the traditional ones where you will see the leakage, you will see the capillary non-perfusion, or the new vessels which might be coming up. Now, looking for the choroidal granuloma, for example, this is the patient. It was actually a case of sympathetic ophthalmia where we truly struggled a lot to make the diagnosis. He kept on developing vascular occlusions. There was diffuse leak on fluorescein till the time you see ICG. You look at the ICG, these small choroidal granulomas studded in the stroma all over. There is sympathetic ophthalmia is the kind of the diagnosis. You just look at it and you say, well, this is sympathetic ophthalmia. Imaging biomarkers, if you want to study OCT, is a very good image. And I mentioned previously TB. This is a large TB granuloma. You will see vascularity on the TB granuloma, which is very important. If ever there is a confusion between TB and sarcoid granuloma, the top panel is TB. TB granulomas are solitary, lobulated, intense yellow, overlying hemorrhages, new vascularization, and outer retina typically shows these changes. Sarcoid granuloma in the bottom are very small, discrete, multiple. They are located in the stroma, so you don't see changes in the outer retina or so much of a bump. And my last was that sometimes patient comes to you, for example, this one is patient actually from this particular city, Kolkata. Now, she has been managed for uveitis, posterior uveitis, serpiginous, doing well, but she's a techie. And she complains of recent onset metamorphopsia, for which she was advised to take a second course of ATT with immunosuppression. So this was the time when we saw her. When you do angiography, there is so much happening, you can't really pinpoint exactly the changes. But if you do your OCT angio, you see there is a new vascular network which is lying there, and that might be the reason why she is complaining. So after discussing with her, I wasn't honestly very sure whether to inject, but we just injected and the configuration of these new vessels changed and her vision improved. We still waited, and without injection, she started deteriorating again. So there may be very fine new vascularization beneath the scars, which are responsible for the symptoms of the patient, and it's not always a recurrence. So please, if the disease does not appear like recurrence, don't start on steroids or repeating the treatment again and again, because that might not be true. And this is just, we have published that these new vessels which they develop in TB are actually type 1 kind of choroidal new vascularization. You may not see fluid, but they will be lurking behind what we call as, very low-lying PED. So to conclude, you have to use these very judiciously. I think TB uveitis, I might have copied it from some other talk, but overall in uveitis. And the imaging modality should be decided depending on what is the phenotype, what is the stage of the disease, and what is the information that you are getting. Always ask yourself a question that this is the answer I want, decide the imaging modality, and when the result of that imaging comes, that answer has to come. It should not be just a frivolous imaging that you want to do everything for everybody because you heard in meetings people talking about, Muller cells or hyelocytes or something. They are good for understanding the disease, the pathogenesis, the newer molecules, but they are not to be extrapolated into your clinical practice day to day. So imaging modality may change from patient to patient. For example, at baseline, you may want to do ICG because you want to see the extent of the disease. But while you are following up the patient, you can follow up the same patient on autofluorescence. And subsequently, when there is cystoid macular edema, you do OCT. And many years later, when there is new vascularization, you look at it and decide what I want to do now. So that's all for today. Thank you very much for giving me the opportunity.